forward to the link. Okay, this is Dr. Gish. We're here to talk about two things. The first part of this lecture is on screening for liver disease and the workup of acute and chronic liver disease. And then the second part will be on alcohol use disorder, alcohol-associated liver disease. If that's okay with everybody. And let's go ahead and get started. Standard of care today is to be evaluating people for liver disease in a variety of different settings. This can be symptom-based, risk-based, and potentially do...
It froze right there.
Okay. It's not going forward. It's going forward on my screen.
Yeah, and I see it over here, going forward here, but not.
And this is not allowing me to go to full screen. I'm going to stop sharing again. Sorry, everybody. That's for the purpose of this recording. I'll try to get the share to work. I don't know why this... There we go. There's two different screens that are open. All right, we found the good one. Now, let's see. Is that going forward? Yes. All right. So have a very low threshold to evaluate people for liver disease. And let's talk about testing just for a moment. So every adult should have an ABC assessment in their chart. Hepatitis A total antibody indicates, if negative, that somebody's at risk for hepatitis A. And if the total antibody is positive, it indicates that they are immune to hepatitis A. So these individuals do not need referral to our liver clinic. That's a common question. So you can interpret that in your clinic and use the hepatitis A test. And of course, if they're A negative, go ahead and proceed to hepatitis A vaccination. There is another test for hepatitis A called IgM. That's for acute hepatitis A, and that's only to be used in the setting with some patients, a patient with very high liver enzymes and maybe abnormal liver function. So, super clear on that one? All adults need the hepatitis B triple panel. We're going to talk about that in detail in a moment. All adults need a hepatitis C total antibody test in their chart. Antibody for hepatitis C indicates exposure, and if hepatitis C antibody test is positive, they need to be reflexed to PCR testing. And then once the PCR test, if that comes back positive, refer them to liver clinic. So hepatitis A don't need to come to liver clinic unless they have evidence of acute hepatitis with high enzymes, plus or minus function. Hepatitis B we'll talk about, but anybody who is surface antigen positive should come to liver clinic. And hepatitis C, only if PCR is positive, they come to liver clinic. Is everybody clear on that? We're good? Okay. We're going to get back to hepatitis B in a moment. Very important in our society with so much obesity to be thinking about fatty liver in every patient. So any patient with any components of metabolic syndrome and elevated liver tests should come to our clinic. Any patient with abnormal liver imaging, ultrasound, CT, MR, even if they have normal liver enzymes, they should come to our clinic. But you can start treating metabolic syndrome in the primary care practice, and of course it depends on the different components, but let's put it simply, for diabetes, everybody should be on metformin unless there's a contraindication, renal failure, or adverse history for metformin. You should be moving to GLP-1 for part 2, or GLP-1 plus something like tirzepatide where you have a dual agonist. The sulfonylureas, the glipizides, the other drugs that we were using 10, 20, 30 years ago are out of date. And drugs like pioglitazone are also out of date. If you need something in addition to metformin and a GLP family, the next option is SGLT2 or even DPP agents. That's really the state-of-the-art portfolio for diabetes. Everybody good on that? We have a label for Ozempic for fatty liver. We also have another drug that we use called resmetirom in our liver clinic. Always take a risk history, because risk history really changes how often you do repeat testing and what repeat testing you do. Of course, immigrants are adults, so they get tested for ABC just like everybody else. The birth cohort for hepatitis C is out of date. I'm just putting it up here for discussion because we already said all adults get tested for ABC. Repeat hepatitis B testing depends on different issues. We're going to get into that in a little bit. One item we don't want you to miss: if somebody's got any type of liver disease and a psychiatric disorder and they're under 65 years of age, get a ceruloplasmin. It's a $3 test. Good for screening for Wilson disease, a copper disorder. We're now ordering alpha-1 levels and genotype in all of our fatty liver patients and any patient with unexplained liver disease looking for alpha-1 antitrypsin. And we have a low threshold for autoimmune disease, but if you think it's autoimmune hepatitis, refer them to the clinic. We'll do that workup because ANA and smooth muscle antibody are commonly positive in fatty liver, and it gets very confusing. So we have special tools to figure that out, including getting a liver biopsy. Of course, if the patient's yellow, you're going to do a whole workup. But remember, Gilbert syndrome is very common. 40% of the population carries one gene, 6% of the population carries two genes. They run high total bilirubin, could be 0.8 up to 3 milligrams per deciliter. But their direct bilirubin is 0.3 or less. We do not need to see Gilbert's patients in our liver clinic. You can figure that out. They have normal liver tests, normal direct bilirubin. They don't need to come to see us. Those patients you can diagnose in the clinic without genetic testing, although you can order a genetic test if you want it. Obviously, any abnormal imaging on physical, any abnormality on imaging and physical, or physical, you need to refer to liver clinic, of course. Unexplained right upper quadrant pain is going to lead to abdominal imaging, and of course, family history of liver disease. I think we're good on this, right? We missed anything? Just chatting to the room here. Remember, there's a difference between liver enzymes and liver function. We don't use the word LFTs anymore, totally out of date. So you have a liver test, liver panel, liver biochemistries. And in that, you have two sets of 4 pillars. Liver function test is bilirubin, specifically direct bilirubin, albumin, INR, and bile acid profile. That's actually 5 tests, but 4 make it sound round. Of course, the other 4 pillars are AST, ALT, ALK-Phos, and GGT. These are liver enzymes. Don't call enzymes function and don't call function enzymes. Be really separate about these 8 pillars, right? 4 and 4 that are here. Fatty liver, of course, is the most common cause of elevated liver tests, but of course people can have fatty liver plus alcohol. We're going to talk about alcohol again in a couple moments. We're going to switch to a slightly different slide deck. But fatty liver is super common, and you can intervene. You send them to the health clinic. You can look at our weight loss roadmap with a weight loss contract, start calorie counting, daily weights, have the patients keep a diary. Find out what's going on psychologically. Many of these patients have PTSD, depression, anxiety. You're the primary care provider. You should be really taking a good psychiatric history. Just another study showing how common fatty liver is. We're able, in the liver clinic, to find the cause of liver disease in 99% of our patients. We have a new genetic panel, which I can discuss later, that you may see in the patient's chart with some very unusual genetic mutations. Those can cause or contribute to chronic liver disease, fatty liver disease, cholestatic liver disease. All right. There are some other function tests that are coming, but not widely used in clinic. I'm just putting that in as a little bit of a teaser. And of course, you're going to be looking at, is it ALT and AST dominant, or is it ALK-Phos dominant? And what's considered healthy for AST, ALT, ALK-Phos, GGT? The lab are pretty good here, but an ALT in general should be less than 25 in women and less than 30 in men. I give a little bit of a buffer up to 30 and 35, but that's the healthy level. If you use that threshold, you're going to detect fatty liver earlier and really help your patients. Alkaline phosphatase is a little bit messy because it's very high in pregnancy. It's high in vitamin D deficiency, which is super common in our clinic. 80% of our patients are vitamin D deficient. Hyperparathyroidism, we pick up a couple people a year who are hyperparathyroid, and also thyroid disease. And of course, AST can come from muscle, especially people who are exercising, working out a lot, muscle trauma, occasionally from statins, although that's probably a 1% rule. This is a very complicated slide on how they figured out this 22 and 34 for healthy ALT, because these people that were included in the healthy group had a healthy body mass index, normal triglycerides, normal glucose, normal cholesterol, and these were people who ended up getting liver biopsies to show they had no liver disease because they were going in to donate their liver for liver transplant, or part of their liver. Take a good medical history, symptom history, really good physical exam, talk about other medical problems, take a good history on herbs, supplements, drugs, and most importantly recently something called checkpoint inhibitors. Take a detailed history on medicines. People typically don't carry a list with them and typically don't bring in their pill bottles. So we're trying to get all of our patients to bring their pill bottles in because it gets very confusing. They're not sure what they're on. They're not sure what they stopped. And people are taking lots of bodybuilding agents and also fat-burning agents. So weight loss supplements gets very messy. A lot of herbs out there. Every year there's 2 or 3 new herbal supplements like green tea extract. Over 100 patients have had liver failure from green tea extract. So extracts, I hear that word extracts and I get very frightened. Social history includes travel. I'll talk about alcohol a little bit later because alcohol history is notoriously inaccurate, but other risk histories are listed on here. Physical exam, we talked about that before. Most of these are just physical exams looking for signs of cirrhosis. But what might be something for Wilson disease would be KF rings in the eyes. Somebody with autoimmune disease might have scleroderma. So do a good physical exam. You can tell a lot. I can tell a lot just by watching the patient walk into the room. You can repeat liver tests, but typically if they're elevated once, they're going to be elevated long term. Although we had one patient in clinic today who I'm sure passed a stone, had an incredible spike in their liver tests, have been stable and normal and healthy since that time. ALT we talked about. This goes into the 6 tests you do in every patient with an elevated ALT, confirmed elevated ALT in this case. I mentioned the hepatitis B triple panel, surface antibody, core antibody, surface antigen. Hepatitis B surface antibody means immunity only if core antibody is negative. Core antibody equals exposure. So once you've been exposed to hepatitis B, you have hepatitis B in your body the rest of your life. Your patient has hepatitis B for their entire life. Even if surface antigen goes negative, meaning the infection is suppressed or controlled, as long as they're core antibody positive, they have a sleeping virus in their liver. Core antibody has a false positive rate of 1 in 500. So you don't vaccinate people who are core antibody positive. There's no natural immunity. That's an oxymoron. So this triple panel is super important. We do not order hepatitis B core IgM unless they have acute liver disease, enzymes over 200. That's super important because a lot of panels give you an IgM and it gives you no true assessment of the patient status. If you're thinking Hep B vaccine, always get the triple panel before you vaccinate. Every year, I'd say this year we've seen at least 10 patients who got referred to clinic for hepatitis B, but they had a vaccine and then 1 or 2 or 3 days later they had the triple panel. And once you get the vaccine, the triple panel for surface antigen will be positive up to 6 to 12 weeks. The hepatitis B surface antigen in the vaccine gets into the bloodstream, and this test is so sensitive, it's going to pick that up. We mentioned hepatitis C antibody, screening for hepatitis C exposure. If they're PCR negative, they've cleared hepatitis C. They're cured. If they're PCR positive, send them to our liver clinic. We can cure nearly 100% of hepatitis C patients. We have multiple drugs to use. Third pearl on this slide is do not order ferritin testing. Ferritin is like a sed-rate or C-reactive protein. It's an acute phase reactant. It's very messy, very difficult to use. We do use it in liver clinic in very special settings, but in the primary care practice, the ferritin is a mess. Fourth pearl, you want to get an alcohol history? You can ask all your questions, no problem, but always order a PEth, P-E-T-H test. Blood test tells you how much alcohol they've been exposed in their blood tests over the last 30 to 45 days. Incredible. Definitely 30 days. Definitely go back sometimes, some patients 6 weeks. Herbal, hilly, supplement, silly, drug, dilly, very common cause of elevated liver enzymes. And then back to metabolic syndrome. We want a BMA, we want a fasting blood sugar, we want a lipid profile, waist circumference, blood pressure, elastography, attenuation score. And I think we should have a hemoglobin A1C in there. I need to add that in. A lot of other things we think about in liver clinic. I'm not going to talk much about this slide. This is our job to work up people who have unexplained liver disease. And we may do much more advanced testing. Liver enzymes, super high enzymes, you can get an acetaminophen level. Super high enzymes, you're going to get a PEth testing for alcohol, as well as taking your history. If the AST is higher than the ALT, in most cases that indicates cirrhosis. It can be a hint that it's alcohol related, but that's why you're going to get a GGT on every liver panel the rest of your career, because a GGT helps figure out what that enzyme pattern is, what the potential cause of the liver disease may be. Talked about AST and ALT, just a little bit more data here. Ratio we talked about. Cholestasis is an impairment in bile flow. Typically, GGT and ALP phos move together, but alkaline phosphatase is very high in children, adolescents. It's very high in women who are pregnant. Healthy, normal alkaline phosphatase is less than 115. This just talks about what this may look like on liver biopsy. We have a pretty low threshold to biopsy patients in liver clinic if they have unexplained liver disease or we think there's an overlap. Fatty liver PBC, fatty liver autoimmune, maybe fatty liver hepatitis B. So we're still doing biopsies. We probably do an order 20 to 30 a year. Does that sound about right? Yeah, somewhere in that range. But this is a special setting. We used to biopsy everybody, but that's no longer needed for hepatitis C or B or PBC. But it's very useful in autoimmune, Wilson disease, different types of overlap disease, cryptogenic liver disease. Biopsies can be quite useful. A little bit more on cholestasis. We think about granulomatous disease like sarcoid or TB, infiltrative diseases like lymphoma. Something that should be on here is something called an IgG4 syndrome that can affect many parts of the body. Of course, cholestasis is the common presentation for primary biliary cholangitis. I need to fix the spelling on here. And primary sclerosing cholangitis. Alkaline phosphatase, this just gives you a graph how high it can be in adolescence. Sometimes I fractionate the alkaline phosphatase, but most commonly I use the GGT to determine if it's coming from liver or from bone. Okay, let's see. GGT is a foundation test for all liver panels. It's on liver panels, but it's not on chemistry panels. So if you're thinking liver, always order a GGT, always order a fractionated bilirubin. I never order 5-nucleotidase. I think that went out 20 years ago. If the GGT and ALK phos are dominant and it's a man, you're going to be thinking about PSC, get an ANCA, get an MRCP. If it's GGT and ALK phos dominant in a woman, you're going to order an AMA for PBC diagnosis. If somebody's AMA positive, they're cholestatic, they don't need a liver biopsy. You can just say they have PBC. But if they have fatty liver and PBC, they do need a liver biopsy. So this takes a little bit of some brain power and fine-tuning. GGT is a strong predictor of cardiovascular events, such as myocardial infarction or heart failure, including cardiovascular mortality. Basically, because the GGT is tracking fatty liver. With fatty liver, you have a high risk of heart disease. So the GGT is very friendly to be used in a variety of settings. Bilirubin, as we mentioned, can be high in Gilbert syndrome. 40% of adults are heterozygous, and 6% of adults are homozygous. These other syndromes, such as Roeder, Crigler-Najjar, Dubin-Johnson, are very rare. I have been fortunate because I do a lot of testing. I've found people with all three of these other rare diseases, but that's not something you need to worry about in your practice. Just think Gilbert's. High bilirubin, normal enzymes, fractionate. Direct bilirubin is normal, 0.3 or less. They have Gilbert's. They actually live longer. They live better. The bilirubin is an antioxidant. A little bit more on direct bilirubin, just gives you some more information. And this is just talks about Gilbert's, how common it is, what the bilirubin levels look like. So there's a lot of data that's on here. So I'm going to stop there for a moment, turn off this one, and then go into alcohol, if that's okay. Did we answer all the key questions that we've been getting fed from the clinics? Okay. We want to make sure our primary care providers are happy. All right. I need to get to... Denise is here. Ooh. Jumping around, getting lots of emails as usual. Now we got it. We're going to talk about alcohol in a little bit more detail since that's so common. This is a lecture from a friend of mine who's at Henry Ford in Detroit. So alcohol use disorder is going up, although it's interesting in the last 1 year, alcohol, especially heavy alcohol use, has dropped 20%. We think it's two reasons. Oh, it's not showing, sorry. I gotta go back. What is going on? I know I had different screens that were going. I'm hoping. That's weird. All right, let's get rid of that. Maybe get rid of this one. Did it go away? Let's see. Yeah, okay, good. I got rid of that. Nice. All right, let's try. Nope. Wrong one. I do want to save that though. And now, screen sharing has stopped. That's okay. And we're back to our main screen. That's good. Let's go back to share. Let's go back to alcohol, and then we're on the right one. Good. All right. And we're still recording, right?
Yes.
Yeah, okay, good. All right. Double check everything. So anyway, alcohol use and volume of alcohol consumption in the last 1 to 2 years is down 20%. One reason is COVID's over. People are drinking heavily during COVID. The second reason is the extremely broad use of GLP-1s. People on Ozempic and tirzepatide stop drinking, stop smoking, stop doing drugs, whatever's going on. So we think that's the main reason that this alcohol use is going down. And there's different bourbon factories that have gone bankrupt, that are closed. Wine industry, sales are down 20%. So if you like wine, you can get great discounts because people are dumping wine on the market. Anyway, these are just graphs about trends and things which are quite interesting. Now, this data is up through 2016, and this kept rising up through 2023. But the last 2 years, this has started going down, which is very interesting. So I need to update some of these slides. Alcohol was the #1 reason for liver transplantation, but this gets very messy because 80% of these people with alcohol-associated liver disease, alcohol use disorder, also had fatty liver, had obesity, had other problems going on. So whether it's alcohol, fatty liver, or combination now, all depends on how you cut the data. So that's why we say people who have fatty liver shouldn't drink alcohol. That's a general rule on that side. And then people with alcohol-associated alcohol use disorder, we need to be aggressive about managing their metabolic syndrome and their obesity. There's a projection that this is going to keep going up, but that red line for strong intervention is what's happening now with the GLPs by accident. It's so interesting. There's other interventions like charging a lot more taxes so the alcohol prices go up. That's another way. Different countries like Finland and Sweden and Norway have cut alcohol use. Denmark, those four, you go to those countries and alcohol is twice the price it is in the U.S. for anything. And the government makes money off that. All right, so making the diagnosis of alcohol-associated liver disease is typically a clinical diagnosis. We usually don't biopsy these patients, but a biopsy can be useful. The Audit C, it shows that if we just take a history, we're doing a poor job, but Audit C is also mediocre. Right now, we are switching to PET testing. They did a urine test called ethyl glucuronide. I've never been able to get this test done, and it's okay, but the labs don't do it, so you can't use it. But PEF has been validated, and this concentration, I don't believe this 8 number. We have people I know are not drinking. They're typically somewhere below 20. And I believe that because I've talked to them and I've talked to family members and other things too. So I think 20 is that threshold, and above 20, then things, of course, can really start going up. I think this 80 is a little bit low for 4 drinks a day. I tend to use 150, but we've seen people in the clinic that have been over 1,000, right? What was that one Cambodian guy who was like 1,300 or something? So it does indirectly tell you volume, but there are other issues like, are you Asian and do you have differences in alcohol metabolism? There's some other ways that these numbers move around. None of these tests diagnose alcohol or alcohol-associated liver disease, but this is just telling you that they are reasonably useful to stage liver disease if people have alcohol. But to diagnose, take a history, Audit C, CAGE, PEF, talk to family members, talk to support people, figure out what's going on with alcohol. There's some special tools, I don't know if it's in this slide deck, that's something like long-term follow back. There's a series of questions like what's the most you ever drank? What's the most you ever drank over a certain time? There's a interesting questionnaire. I used to use the Michigan Alcohol Self-Assessment Test, which I still like a lot, but it's not commonly used anymore. Treatment. We're never, in our clinic, we should never be treating alcoholic hepatitis. We should be sending them to get worked up at UCSD or Scripps. Prednisolone improves survival to 28 days, but does not improve survival to 90 days. There's some historical issues. So it can make liver tests better. There's a lot of rules around using steroids, but this is really an inpatient question. Abstinence is key, and this just has to do with drinking alcohol. Drinking alcohol on top of fatty liver can get these incredibly sad cures. If you have a team approach for managing alcohol use disorder, alcohol-associated liver disease, it clearly makes a big difference. And who do we have in the SUD clinic now? Sergey was still there. Okay, he's great. I'll make sure that hadn't changed. Yes, we've got that. Disulfiram, completely out of date. I haven't seen anybody on that in 20 years. Naltrexone, we like, but I usually like to have Adler prescribe it or to go to the clinic.
Oh.
It's a controlled substance also, right?
The naltrexone?
It's not? You haven't seen it? I don't think anyone.
Vivitrol, isn't it?
Vivitrol maybe, okay. Gaprosate's good, gabapentate's good, topiramate's good. Baclofin's my favorite one to start. I usually start here and then work backwards to naltrexone. But treating their depression is super important. It's really find out what's going on psychologically and then using combination. What's your favorite one on here? Do you have one?
I've been using baclofen based on your teaching, but we see a lot of patients when we send them to behavioral health or substance use. It's Vivitrol.
Vivitrol there. That's the injectable.
That's the injectable. Yeah,
right.
The monthly injectable. And I think patients prefer that. Some of them are the oral, but many of them are injectables.
So I'm hearing baclofen and naltrexone because that's Vivitrol. And the rest of them are good too, though. Everybody I've talked to has got a little bit different feeling about what works. So I think a lot of it has to do with what interventions you have. And there's a lot of data on how these are useful. And it's really, I'm just putting this up. I'm not going to walk through it, but it is data driven. And people live longer, live better. They're on treatment. It's amazing. A lot of data behind that. So medications for alcohol use disorder improve survival. This just has to do with how we interview. This ORS, motivational interviewing, is really nice. I try to weave that in when I'm talking to patients, kind of depending on what the chemistry in the room is. And the rule is, if you transplant somebody for alcohol use disorder / alcohol-associated liver disease, the relapse rate over 5 years consistently is 30%. Now, among that 30%, 1/3 are heavy, 1/3 are moderate, and 1/3 are occasional. So it's not a total disaster. So 1/3 of 30% is 10% go back to heavy, self-destructive drinking. Some people think that's fine. Other people think that's stupid because we shouldn't be giving them livers that are going to drink again. And there's pretty good prediction. This is Brian Lee, who's at USC, talking about how to measure and how to predict drinking. It has to do with support, depression, employment, insurance status. There's a number of different factors that are very obvious to us that come into this prediction. Early listing. Some people have been listing people who come in with alcoholic hepatitis who were drinking till a week ago. So is it their first event? And there's some issues about psychiatric, psychological. Is there a commitment? Is there awareness? Is there insight? Is there family? Do they have life insurance? Do they have more than one supportive person? On the flip side is if they failed rehab in the past, terrible sign. So they've been in and out of rehab, that's a really bad one. What about using drugs plus alcohol? Very bad sign for drinking and doing drugs again. And maybe that's the last slide. Let's see what's going on. Yeah, that's the last slide. So this is things that we do, I think, consider in our clinic, but it's really case-based. It's very individual. So did we miss anything for teaching our new staff?
No, I think you covered it. It was on repeat testing, and you covered that, as well as the antibody testing, so I think that was pretty clear. So
Got it.
I'm sure it gets to that.
All right. And then somebody will send this recording out to the team, right? Thanks, everybody. I'm going to turn off the recording.